All right, we'll call this meeting of the Assembly Health Policy Committee to order. It is January 6th, 2021. Happy New Year, everyone, and welcome. Carissa, could you please call the roll?
Yes. Ms. LaFrance.
Here.
Ms. Zolotel.
Here, thank you.
Ms. Allard.
She is excused for today, thank you.
Okay. Mr. Constant. Mr. Dunbar.
Here.
And Mr. Rivera.
Present.
Thank you.
Thank you. So my name's Meg Zalatel. I'm co-chair the committee with Ms. Suzanne LaFrance, and we have a packed agenda today. We have 3 items from the health department, and then we're going to discuss industrial hemp products. So I'm going to turn it over to Heather Harris, the health department director, and her team. They're going to cover 3 items: the data dashboard updates, vaccine status, and public health 3.0. What I'm going to do is let her really just have this time, about 35 minutes for all 3 items. But when you get to the end of each item, Ms. Harris, if you want to let me know, and then we'll see if there are any questions in the queue. If you'd like to get in the queue, of course, please use the chat function. And if you don't have that, let me know, and I'll make sure to find out a way for members to otherwise get in touch with me. All right, Ms. Harris, the floor is yours.
Wonderful. Thank you so much. I think I will turn it over to start out with the data dashboard update to Dr. Johnston. Dr. Johnston, are you with us?
I am. I was on mute.
Okay.
Sorry about that. I'm just going to share my screen. Can you see that?
Not yet. Maybe we need to take down the agenda first.
Okay.
Now please try.
Okay, let's try this again. Okay, can you see it now?
Yes, and I believe we've been joined by Assembly Member John Weddleton as well. So please go ahead, Dr. Johnston.
Great, thank you.
And Mr. Constant.
Thank you.
So this is the homepage for the Muni's coronavirus response. I'm sure many of you are familiar with this. If you scroll down, you see some of the key numbers that we keep up here on a daily basis. One of the main ones that we refer to is this 14-day case rate per 100,000, which is averaged over the past 14 days. And this is based on the daily reports of new cases. So at this point, we're at 36.27 cases per 100,000 per day, which is translate to about 106 new cases per day across the municipality. And this is a 20% drop from last week and a 60% drop from December 1st. So you can see that also in the graph above, where we peaked in November, and now we've been coming down. Might be a little hard to see right here. It does seem like we're leveling off at this point. The numbers are a little hard to interpret right at this moment because of the holidays. So with some decreases in testing, and now starting to have people go back and getting more testing after holiday travel or gatherings, we'll have to see what happens with that. But what I really wanted to go to was this stoplight roadmap metrics that we looked at last week, or last meeting, because since then we have added links to various graphs that support the colors on these stoplights. So looking at epidemiology, we look there at case trends and hospitalization trends. And if you click on the open case trend graph link, you get the graph that I was just showing you, which is the cases by onset. This is a slight bit different than cases by report date, because what we do is we take the cases that are reported yesterday, there were like 63 of them. 7 of those had actually come from tests that were done yesterday. The rest of them had been from earlier testing dates. So we assigned those onset dates usually to the testing date. So this, I think, is the most informative graph in terms of what's going on with the trends in incidence of the virus. And again, we peaked in November, we're coming down, and we are looking like we're flattening out here. We stopped this graph, the line of the moving average, 7 days prior to today's date. The reason for that is that we need time for people to get tested, get the test results back, get those results into the database from state section of epidemiology. So the onset date for the past 7 days will often be artificially low until we get back all of the test results. Then if we click back on return to the stoplight dashboard, and we go back to where we were, I guess I would also say, so we have the trends, we've kept those in a red status. The reason for that is that even though the new cases per day have come down significantly, we are still at a very high level of virus within the community. And to give that some context, we're 2.5 times the CDC's highest risk limit related transmission in schools, and about 10 times their limit for the moderate risk of transmission in schools. And I really feel like that moderate risk, given that we're looking to open schools later this month, it would be great if we were at that moderate level. We're also 3.5 times the state high alert level. So lots of really good progress since November, but still high enough that we're still very concerned. Then the hospitalization trends. This is a graph of the confirmed and suspected cases in the 3 Anchorage acute care hospitals. And this graph only goes back to November 7th. That's a data issue. There were some changes in the reporting data. You can also get this back to the beginning of the pandemic by looking on the state website. But what we've got here in red are the confirmed cases. So today we have, or yesterday we had 51 confirmed COVID cases in the 3 hospitals, and then another 7 suspected cases. And what you can see here, the reason that we changed this from red to yellow is that this during second half of December did come down consistently for a 2-week period. Again, as we get into the holidays, people do try to be out of hospitals as much as possible over the holidays. So it's a little hard to tell what's going to happen now. We've leveled out, came back up a tiny bit after in between Christmas and New Year's, went back down again. And now we seem to be trending back up, but we'll have to see whether that will continue. And we focus on 3 areas on this dashboard: epidemiology, healthcare capacity, and public health capacity. For healthcare capacity, probably the thing we look at the most is the ability to handle an anticipated case surge. And the graphs that we focus on for that, again, we look at the number of hospitalized patients, and then we really key in on the number of available adult staffed ICU beds. And this goes back to September. What you've got on the top, the white is the number of available beds, and then the blue and the white combined are the total number of staffed beds. So we have 7 available ICU beds as of yesterday out of 67 staffed beds. And then you can see again, around the holidays, there was a little bit of freeing up of beds, and now that's becoming a little bit more constrained. But we are in a better place than we were at the end of November. On November 30th, there was only 1 available ICU bed among the 3 Anchorage acute care hospitals. So that was obviously extremely concerning. Then we also look at whether we have sufficient PPE available for healthcare workers. We don't have a really good graph for this, so we have not provided a link. Mainly in deciding where to set this, I focus on the reports from the Emergency Operations Center because they handle all of the requests for PPE. So they're aware both of what our supplies are and how much demand there is from local providers and first responders. This is set to yellow and has been for a while. It'll go to green when we don't need to have the EOC providing PPE, and it goes to red if we've got critical shortages. But basically, we've been in a situation for the past couple months where there are some providers, mainly smaller providers, who need some help getting PPE, but in general, the EOC is able to handle all of those requests. And then we focus on testing, and we focus here both on how many tests we're doing, so really testing capacity, and the percent of those tests that come back positive. This bottom graph here is the number of tests done each day. The red are the daily positive results, the green are the negative. And again, with the holidays, these numbers are all a little bit hard to interpret, but we are seeing slightly lower volume of testing than we were in November and early December. We are hoping to see that go up a little bit more. We're definitely encouraging more proactive weekly testing among certain populations like grocery store workers, frontline hospitality workers, and teachers. We're working with the school district to encourage teachers to get tested in this time before they're going back into the class, or before they're going to have students coming back into the classroom. But Anchorage is in very good shape in terms of testing volume. Early on, there was a lot of concern about whether we would have enough supplies for testing, but we now have sufficient supplies. We have a good contract with Visit Healthcare for the sites around town, and we've seen improvements in the turnaround times and the wait times. So that's actually one of the things we've just been talking about, is now focusing on communications to make sure that people realize that we do have that capacity. The waits are not very long and results are coming back quickly. This top graph is the percent of positive test results by date collected. And again, you see we peaked with positive tests in mid-November. And we also, so when we peaked with the number of positive tests, we also peaked with the percent of positive tests. Our average peaked at over 10% in November. We actually came down below 5% in December, although we have now gone up above 5%, but just a little bit. 5% is what we've been using as the goal, although the WHO has since said that the countries that are doing the best job in controlling the virus are at a less than 3% positive tests. But we've used 5% for the green here. So we did change that to green last week, although I think there's a good chance that will go back to yellow, as we seem to be consistently just above 5% at this point. And then we have the public health capacity metrics. Again, these do not have actual graphs with them. This is more qualitative. And these have turned red because neither the Muni nor the state has the capacity at this point to interview all cases and monitor all contacts. We are seeing, as case counts are coming down, that we are getting that more under control. So we are monitoring this. There's also been, it's been evolving how we handle case interviews, how we do prioritization. There had been a move away from source investigations when we had so many cases, but we are now moving to a point of focusing on interviewing the most recent cases, because the sooner we get somebody into isolation and we get their contacts into quarantine, the most it's really the most bang for our buck in terms of containing the epidemic. So we're focusing on the closest cases, and then we are working on case investigation, which is where we try to figure out where someone may have gotten the virus, but rather than looking at the full 2 weeks before they tested positive, we're focusing on 5 days. So someone it can take 2 to 14 days after an exposure to actually be infected and test positive. But we find in general it's 5 to 7 days is the most common. So again, in order to maximize what we get out of these interviews and minimize the time it takes, we're focusing on the 5 days before testing.
Dr. Johnston, if this is an okay time on the data piece to go ahead and interrupt for a few questions. I know we're going to run short on time otherwise.
Yep.
Okay, Mr. Weddleton, go ahead.
Oh, hi, thanks. I think a couple of questions pop out is, we've been focused on protecting ICU bed capacity, and it seems like that the number of existing beds, I mean, not just the capacity, but that can change. And I was curious and maybe I misinterpreted that graph, but it's not like we have 70 and we always have 70. Seems like that bounces around. Sometimes we have 72 just existing. And then another thing is, all this stuff we're doing to, mitigate COVID-19 should also decrease people getting the flu if it's working. And do we have stats on how bad the flu season is so far?
So I'll answer that question first. I haven't actually looked at the stats lately, but my impression is that the flu season has been extremely light. And I don't think it's really even kicked in very much yet. So you're right. That's one of the big benefits that we're getting. We also really pushed flu shots earlier in the fall, and we did have a good uptake on flu vaccines. So that's a benefit, and that is helping to protect our healthcare system. And you're also correct that number of available beds really fluctuates. And it was interesting, in September, the reporting mechanisms from the hospitals to the federal government changed. Prior to that, they seemed to be using as the denominator, it seemed to be about 82 available beds was usually what was reported. And so I think that had more to do with physical beds or licensed beds that they had for the ICU. Now what we're seeing is that it does fluctuate up and down, often between 65 and 74 is the range I see most often. And so that has to do with staffing. And the hospitals they're sort of walking a tightrope. They don't want to have a lot of staffed beds that are empty, because then, they could be using that staff for something else. But they also need to have enough that if there's a surge in COVID cases, or if there's a bus accident, that they have those beds ready to go when they need them. So there is flexibility there. And that's one of the things we talk with the hospitals about. But the other thing is that with so much community transmission, and this should improve with the vaccination of the healthcare providers, but there was a point when they got to the only one bed available. That was a combination of they just didn't have the staff as well as the beds, because they had so many people who were out either being sick or quarantined or in isolation.
Okay, thank you.
Sure.
Thanks, Meg.
All right. So I think at this point, if we can turn the conversation over to the next item regarding vaccine, and I don't think we're going to have time to discuss Public Health 3.0 today, but maybe we can move that to next month. So we want to leave time for our conversation about industrial hemp. If that works okay, then I will we'll go ahead and start the vaccination plan update.
Great.
Sounds good. And can everybody see my screen presentation?
Yes, and for those on the phone, this is on the committee's webpage. Thank you. Please go ahead.
Wonderful. Thank you. Thank you for the opportunity just to have this conversation and give a bit of an update around the vaccine rollout. In December, the EOC provided information about the rollout of the vaccine at the Joint Assembly School Board meeting. And so this is just in addition and kind of giving an update as to where we are at this point. Here at the health department, our purpose is public health, working for all of us all of the time. And that is very evident as we are navigating this global pandemic and very relevant to the vaccine rollout. As we can see here, this is an image that the state provides, which is a great just image to help us understand where we are as we navigate and move through vaccine availability. The phases refer to the levels of vaccine availability as we progress, and as more vaccine becomes available and more widely available, we'll be able to move through these phases more quickly. And as a reminder, there are multiple vaccine candidates that are being evaluated, and with additional vaccine, hopefully we'll have access for more residents in Alaska to have the vaccine. This is the timeline that was shown at that joint school board assembly meeting. And so I'm not going to go into great detail about this right here, right now, but just a couple of highlights that we see in September 16th, the CDC released their COVID vaccination program interim playbook for jurisdiction operations. So that's the guidance on how to plan and operationalize the vaccination response to COVID here in our community. In December, the ACIP, which is the CDC's Advisory Committee on Immunization Practices, voted to recommend the initial vaccine allocations go to healthcare personnel and the LTCF residents. And then December 11th, the FDA issued the emergency use authorization for the Pfizer vaccine. So that's where our timeline really starts to pick up quite quickly. As we can see from the continuation of the timeline in December, the first vaccine landed in Alaska on December 13th, and healthcare workers were starting to be immunized, given the vaccine on the 14th. On the 20th, the ACIP provided recommendations around phase 1B and 1C. And through the month of December, throughout the state of Alaska, there were over 13,000 doses administered of the vaccine. Also, at the end of December, the Alaska Allocations Committee provided guidance on their phase 1B and the sub-prioritizations. In January, we have started to see, just in the few days that we're into January at this point, on the 4th, phase 1A, tier 3 started vaccinations at 13 sites. And as of today, phase 1B, tier 1 can register for vaccines as of today at noon. And those vaccines for phase 1B, tier 1, administering of the vaccine can start on the 11th of January. We are the timeline for the Alaska allocation to determine phase 1C is still yet to be determined. Here from this slide, you can see this comes from the ACIP and gives the overview of how the phases move forward. I really want to draw your attention to the top right corner where we can see the estimated kind of process and how these phases will move forward between the phase 1A, B, C, and then into phase 2. And you can see that as we start phase 1A, that will continue. And phase 1B can potentially start before all of phase 1A group has potentially received their vaccine. So we'll see some blending as we move forward. As I shared a moment ago, the Alaska Allocations Committee has determined sub-priority groups for phase 1A through, which it has 3 tiers, and phase 1B, which has 4 tiers. And we have not yet received guidance on phase 1C. There is a public comment meeting that the Alaska Allocations Committee has planned and will occur on January 11th. And so if there's interest in more information about that meeting or how to provide comment, there's more information about that on the Alaska Vaccine Allocation Advisory Committee webpage. I want to really just take a moment to highlight the great work that's happened here at the municipality. We saw in that phase 1A tier 2 that fire and EMS and those performing vaccinations were able to receive their vaccination. And we were allocated over 500 doses, and we have been able to dispense over 600 total doses to fire, EMS, and those performing vaccinations. And we've been able to do that with 0 waste and 0 expired. And these numbers are as of December 31st. As we start to look at phase 1A tier 3, those are workers in healthcare settings, and we in the state of Alaska, we are getting our monthly allocation numbers. Previously, we had anticipated that we were going to receive our allocation amounts on a weekly basis, and that did shift, that we are able to know those allotment numbers for the entire month of for each month. And so for the entire month of January, our statewide vaccine allotment includes over 27,000 of Pfizer vaccines and 25,000 of Moderna. Again, those are statewide numbers, not necessarily just in the municipality. And as we work through this tier, phase 1A, tier 3, we are actively recruiting and encouraging, as is the state, for sites to respond, to become sites for vaccination dispensing. And that will really increase the availability of the vaccine throughout the state, and specifically here in the municipality. So if there are areas, or if there are providers out there interested in receiving more information, there's great information on the state site. We recommend them taking a look and considering becoming a location for vaccines. As people are trying to access the vaccine, clinics are either come in two different ways. They can either be public or private. And the public is a first come, first serve by appointment based only. And the scheduling for that is on the state website. There's 13 sites currently live on the state website. And for private appointments, those are also appointment based, but they are for internal clinic staff only. And our providers are being asked if they can, how many doses they can currently provide to their staff, and then also potentially for the general public as well, but that's not yet moving forward. Also, continuing in this conversation around healthcare for workers in healthcare settings, those vaccinations, as we shared a moment ago, started January 4th. Here at the Anchorage Health Department, we started our vaccination site yesterday on the 5th, and we anticipate administering 400 doses in the month of January. That's about 30 to 40 doses a day, and the EOC is supporting in that effort with PPE orders. We are working with the EOC and AHD about potentially offering a site at the training center, which could increase the number of doses that we're able to administer in a day. And we continue to just work through logistics and how we can provide as many vaccines in a day as possible. The Anchorage School District has been able to set up a site in their education center and is able to administer 200 doses a day at this point. Next, this slide is about is looking at the allocation, the Alaska Vaccine Allocation Advisory Committee's guidance on phase 2B is we can see there are 4 tiers. This information, there is a lot of details in this information. There's a lot of information on the slide. I highly recommend taking a look at the state website and pulling the guidance from the Alaska Allocation Committee for more detail. But at a high level, for phase B, 1B, tier 1, that is for persons aged 65 and older. As we go into tier 2, we start to look at the frontline essential workers, specifically those who are who are 50 and older, and their work duty must be performed on site. And the tier 2 also includes people living or working in congregate settings. As we go to phase 1B, tier 3, this is persons aged 55 to 64, or persons living in unserved communities, or essential workers aged 16 to 50 with 2 or more high-risk health conditions. Again, that their work must be performed on site. And then as we look at phase 1B, tier 4, we move into persons aged 50 and older with 2 or more high-risk health conditions, or frontline health workers, again, aged 16 to 50 who were not previously covered in the tiers 1 through 3, again, whose work has to be performed on site. So a lot of really great information here about who is prioritized. It can get complicated, and there's a lot of detail here. And so, again, recommend just reviewing and going to the state site to receive the full guidance to understand those details.
Thank you, Director Harris. We actually have a question here. Mr. Dunbar.
Yeah. Thank you, Madam Chair. And I was going to hold until the end of the presentation, so I apologize if this is jumping the gun on a slide that you have later. But because of how complicated this is and how many slides there are, I think I want to ask now, while there's this in front of us and we're just a few slides away from the other slide that had the different phases there showing 1A, 1B, 1C. And if you look at that slide, 65 plus is phase 1C. Not 1B. 1B, or I think maybe 1A is 75 plus. And so my question is sort of what changed, and to what degree, if at all, will the shift from going to 75 plus to 65 plus, regardless of work status, how will that potentially slow down or delay the vaccination of essential workers? And I'm thinking in particular, if you could speak to the education sector, because of course we are asking them to go back into in-person school in just a couple weeks.
Yep, absolutely. Thank you for the question. So where we see the phase 1B for persons 75 and older, that was guidance that came from the ACIP. States don't necessarily have to follow all of the specific guidance from the ACIP. They often look to and align to the ACIP recommendations, but we saw that our state allocations committee did make that determination in phase 1B, tier 1, to bring that age requirement all the way to 65 versus the 75. And so that's where we see the discrepancy in those numbers, or the potential confusion there, because phase 1B, tier 1 only includes persons 65 and older, and we don't start to get into the frontline essential workers until tier 2. It will delay the phase or the tier 2 essential workers, including teachers. It's uncertain how long it will delay those individuals, because we are preparing and planning for high and low level availability of vaccine, and obviously the hope is that as more vaccine becomes available and approved, that we'll be able to really move through these phases as quickly as possible. So uncertain about the timeline, but you are correct that it could impact frontline essential workers such as teachers and
Can
their
I ask a
availability
follow-up?
for those under 65. Mhm.
Yes.
Sure, please go ahead, Mr. Dunbar.
Thank you, Ms. Zalatel. And I suppose it'd be interesting to hear from the school district what percentage of our teachers are over the age of 65. I would guess that it's a relatively small percentage. But I had spoken at this committee before and asked the municipality to advocate for trying to get teachers moved up in priority because we wanted to reopen. And I understand this is all coming down from the state, so we have limited ability to impact it. But I'm wondering if you could walk me through the logic of, we certainly want to vaccinate everyone we can, and people with 65 and older have a higher risk of being having severe reactions and being hospitalized if they get the virus. On the other hand, we teachers in particular, we're putting them in an environment and a number of other essential workers where they are just vastly more likely to be infected than someone who is perhaps retired, for example, and doesn't have to stay in a room with 20 other people for many hours at a time. So can you try to walk me through the logic from this committee as to why they felt that risk was not substantial or was outweighed by the other factor of lowering the age 65?
I can do my best to share information that I do know. I'm not, I think that a bit of that question probably goes to the actual Alaska Allocations Committee to be able to speak to. I do know that they are focused on similar metrics or similar factors such as the ACIP around making sure that they're paying attention and watching the science and thinking about the implementation and the ethics of how they distribute the vaccine and prioritize groups. The Alaska Allocations Committee also received over 300 comments within a pretty short period of time and feedback about which group should be prioritized. And so I'm not sure that I can speak further than that about their decision making about those essential workers and putting them after those that are 65, with the exception that those over 65 also, as we've seen in our data, is that they have much higher impacts when they medical impacts when they contract COVID.
Right.
I don't know if anybody else from the health team has more, or from the AHD team has anything to add to that.
Yeah, Heather, the one thing I can add, if you want me to go on.
Sure. Just I want to do a little bit of a time check here. So we have one other item we definitely need to get to on our agenda. So Dr. Johnston, add to this. I also want to note in the for the record in the chat, Dr. Johnston shared the phase 1B allocation plan from the state website and gave us an update on administered vaccines of 848 as of January 5th. So please go ahead, Dr. Johnston, and then Ms. Harris, if you can try to wrap up quickly, and then we're going to have to move to that next agenda item.
You got it.
So one of the things I was told is the state went for the lower 65 rather than 75 because in Alaska we have more of our seniors who are being cared for in homes or in smaller assisted living facilities. And so in other states, that 65 and older would have been handled by the federal healthcare partnerships more than they are here. And so they felt that that was an important reason to lower that limit here. But we will have, some percentage of those covered by the pharmacy partnerships. So that will help move us to tier 2 quickly. And then those frontline essential workers over 50 in tier 2 will include educators over 50. So whereas we don't have a lot of teachers over 65, we do have a percentage of 50.
Great. I'll run through these last slides relatively quickly. We're planning for high versus low vaccine availability, recognizing that in these early stages, real low availability, and trying to determine and get the vaccines in arms of those most at risk. And then also thinking about the other side of it, of having a lot of availability, and recognizing that we've got a big lift ahead of us to vaccinate our entire population, and to not just do it once, but to provide a shot a second time. So lots of plans are happening right now to plan for these different availability levels. Part of that is working with a contractor, or developing a scope of work for a contractor to help support the distribution and administering of the vaccine itself. And that would also ensure this equitable distribution of the for persons that have less access to established providers. And just how you can impact the success. Right now, we are absolutely encouraging providers to enroll and become a vaccine administrator. That will give us more shots in arms in a quicker fashion when we have that higher availability of vaccine. Also just sharing messaging and public education about the vaccine, and really pointing to the state website at this point in time about the great information that we can see there. And when it becomes your turn, and if you're willing to get vaccinated, to do that, and also talk about why you did. And that's what I've got for today.
Thank you, Director Harris. Appreciate that. Very informative and a lot of information. We're going to turn to the item on our agenda, industrial hemp. And to kick that one off, I'm actually going to invite a guest, Mr. Robert Carver, to speak a little bit about industrial hemp products and regulation. And then if the health department has more they'd like to add. We have about 15 minutes for this conversation. So Mr. Carver, are you on and able to hear us?
Good morning, this is Rob. Yes, I am on, and
Okay.
I hear you well.
All right, please go ahead.
Well, again, my name is Rob Carter. I work for the state of Alaska, Department of Natural Resources, Division of Agriculture, and operate the Alaska Plant Material Center out in Palmer. One thing that was new for us in 2020 was the rollout of an industrial hemp pilot program for the state of Alaska. In that, it follows guidance provided in the 2014 and 2018 farm bills, which legalized the legitimacy of an industrial hemp industry across our country, as long as a state had the law and the regulations in place to provide opportunity for registration. In short, to grow, process, or market industrial hemp or any derivative of industrial hemp, you must be registered directly with the USDA or the state in which you reside or are doing business. I think that, again, trying to keep this short for you guys, our intent is to get people to produce industrial hemp around the state. We did have production in 2020. It was an exciting year to roll out a new program. We had about 70 acres around the state in production and about 9,000 square feet of indoor greenhouse space. We have currently 3 processors in the state that are registered with us to process industrial hemp from its raw form into another form. And we're sitting somewhere about 150 retailers around the state. And this is for any individual that's offering for sale, again, industrial hemp in any form. Really, the legislative intent behind this was to explore this new agricultural opportunity. For those that don't know the difference between industrial hemp, it is cannabis sativa, just like the recreational side of cannabis, but it is defined as having a THC concentration at less than 0.3%. Again, we're working hard. Last year was a tough year to roll out a new program to educate individuals before we start our regulation of these individuals, to get them to understand both state and federal law. And the intent behind the program is to develop a new industry, make sure the products that are available out there are safe, tested safe for the consumers that are utilizing them. I believe that I've been most likely asked to be here to introduce you to our program and to this, as there's been some stuff moving around in the municipality that has to do with electronic smoking devices. Some of those do tend to be derived and have industrial hemp products in them. And in all senses and sorts, any product, again, if it's in a vaping device, a lotion, we define it as consumption, which also includes absorption. This would be your, most people are familiar with CBD, as it's kind of the popular one. There's a multitude of other cannabinoids out there, CBA, CBG, that also provide wellness benefits to the consumer. So anybody that is using those in or on their bodies, those products must carry an active endorsement with our program. That endorsement is provided to us by the manufacturer or the retailer, where they can provide us a certificate of analysis showing us that the product has been tested safe. I know a lot of people are familiar with that in the community because of the recreational cannabis industry. Ours is a little different. We go beyond the testing that's on the recreational side. So this is, again, really trying to protect the consumers. We've identified that majority of the products that are derived from industrial hemp are used for wellness. And of course, the FDA says there's no medical claims, so we've dubbed them wellness products. But again, those are there, and our testing guidelines and our contaminant levels are there to protect the consumer from pesticides, heavy metals, residual solvents, micro and microtoxins. Is there any questions at this point from any individuals?
Yes, thank you very much. Mr. Constant.
Yeah, thank you. So you just mentioned testing of these products. Your testing requirements are strictly on those products that are manufactured in Alaska, correct?
It's actually any product. One thing that I am not a lawyer, I'm an agricultural individual. Any product that is for human or animal consumption is full panel tested. So it's not just the ones in the state, it is any product being offered in the state.
So Fred Meyer, if they wanted to sell a CBD product, would have to run it through testing, even though it came out of California.
Generally, we don't see the retailers like them carrying the endorsement. It's actually the manufacturer. We have a lot of products from out of state. We're not the only state that requires something similar. But yes, those products would also carry an endorsement. There is an option in the regulations for a business such as Fred Meyer or, CBD shop, as a hypothetical.
No, not a CBD shop. I'm sorry to interrupt, but there are, I think, Natural Pantry sells CBD products. There are a number of stores that already do.
And the products that they would carry would technically need to carry an endorsement so that we and the program and the state of Alaska and the consumer could know that they were tested safe.
Oh, interesting. Okay, so then this is a new requirement. When was this levied onto the industry? Because this is first I've heard that in order to carry a retail CBD product, you have to have a tested product. So Senate Bill 6 that was passed through the Alaska legislature was 2018, signed into law then. Our regulations were not effective until April 4th of 2020. It took us a little bit of time to draft the regulations. During that drafting of the regulations, I will say we had some resource challenges and kind of parked the project and then restarted the project and again came into effect April 4th of this year. Okay, well, it's interesting. I look forward to learning more about that. Do you have any publications on how this whole thing works?
We do have a website. I can probably put it in your comments section here. I'm hoping, let's see if we can do this. This is us. Again, I think that you can go there, you can kind of see our application process. You can see a list of endorsed products. It's trying to be updated as much as we can. Like many other programs, we were not given the funding to do this. The funding to roll out this program has to be generated from the fees. So we set fees for production, for retailing, and for processing, as well as endorsement fees, and that covers the cost of operating this program. Again, it really provides the legal opportunity under the 2014 and 2018 Farm Bill for an industrial hemp industry in the state of Alaska. It really helps both the consumer and us as the regulating agency to know what products are out there, what's being offered for sale, and that they are truly an industrial hemp product, and then again safe for the consumer so that they can continue to benefit what it's kind of been a gray market out there for a significantly long time.
All right, so then last point I guess I would make, would it be fair to reason the argument then that any of the products that are then being sold in any of these locations that have this endorsement are with products that are generally believed to be healthy and safe because they've been reviewed and meet the standards that you have under your regulations?
Yes, we can't direct what people do with the product when they get it. But we do tell people that those products that carry an endorsement through our program have been tested safe. We use the words tested safe because we don't test in every individual bottle of tincture or salve or cream or gummy bear, but we do test representative samples of the lot or batch.
Thank you very much.
All right. Thank you, Mr. Constant. Thank you, Mr. Carter. For the record, the website provided, it's plants.alaska.gov/industrialhemp.htm. And for those on the phone, does the health department have anything they'd like to share with regard to industrial hemp? We have about 3-4 minutes, and then I want to turn to audience. I want to turn to the rest of the agenda. We have legislative budget priorities and audience participation.
Just a quick comment. Our research didn't necessarily find any public health guidance on this type of restriction and nothing on hemp retailers in particular. And so, and we didn't find anything in any other states or municipalities. And for that reason, the public health implications for this particular exemption is unclear. And so the health department doesn't have anything further on the topic.
Thank you, Director Harris. Last call for questions on the industrial hemp topic. I want to thank Mr. Carter for joining us today and providing all of that great information to us. Okay, turn to legislative and budget priorities. I don't believe myself or Ms. LaFrance have anything specific we'd like to discuss, but as always, these are standing items on the agenda. If you would like to raise anything, now is your opportunity. Okay, I'm not hearing from anyone on that. So we'll go ahead and turn to audience participation. I did have one audience participation request that I'm going to start with, and then we should have time for additional audience participation. Please remember your participation is 3 minutes. If you are on the phone, you'll press, I believe, *6 to unmute. And we'll start with Mr. Corey Ace. Can you confirm that you are on and can hear us okay? Oh, I heard someone for a second and then they faded back out. Can you try again, please?
Yes, I think I'm on now. Can you confirm?
Yes, please go ahead.
Thank you so much. And thank you for everyone's hard work in this unprecedented situation. I am the president of the Anchorage Education Association, and I'm working closely with the Anchorage School Districts in all aspects of getting our students and educators back into the classroom. I have a request that we update timelines and make adjustments so vaccination distribution coincides with the face-to-face learning timeline. ASD is pretty set in going back to face-to-face learning for our youngest students on the 19th, and it is very frustrating that these timelines are not being considered and that they don't coincide together. If you look at the A1 Tier 3 and you were just to switch workers in healthcare from workers in education settings, the educators would qualify under the A1 Tier 3. So looking at that, we need to help our educators going back to face-to-face learning. It's not every educator in the Anchorage School District. It's those that are volunteering to go back and involuntarily going back to the face-to-face learning environments. ASD has triaged the workforce, and we just need approval to begin distribution of the vaccines. We're triaging based on those going back to those environments, as well as educators who might have compromising immune systems or any other condition that might make them vulnerable to COVID-19. It's important to also realize that there's a vested interest in the community to vaccinate teachers, as they are could be potentially epicenters for spread as well to groups of students, and then those students would go home and spread it wider within the community. I want to thank you for your time. I want to thank you for your efforts. I don't really know who else to talk to advocate for a change in timelines, but I'm willing to take that feedback, and I will call and continue to advocate. I appreciate the time. Thank you so much.
Thank you. Do we have anyone else who would like to participate?
Hello? Hello?
Yes, please. Yes, Mr. Haberman, I can hear you. Please go ahead.
Okay, start my timer. My name is Eugene Carl. I live in the Valley. All the public process, when the public process is done appropriately, decision made by the governing body is more likely public interest. First of all, I know it's been difficult for all of us dealing with COVID, but it's been a problem with the Assembly and administration at the Assembly meetings. You've done improvements in dealing with COVID as far as handling with the members of the public and the Assembly there, but there's still a problem, and that is this. You require members of the public they need to wear masks. The problem is they're not complying with it. A sizable majority of members of the public that are attending those meetings are not compliant. They're wearing holiday hats as masks, and also a problem is you made an exemption. When I say you, I mean the rules of the Assembly meetings were that when members of the public go to the microphone, they can take off their mask. That is a serious health issue. You need to be consistent and say masks are required and not to be taken off. So, but I'm also want to take this next point and critical. We're moving into this area of people being vaccinated. What concerns me is this long period in our country, in Alaska, in Anchorage, and elsewhere, where there's been resistance to wearing face coverings. Well, just because members are being vaccinated doesn't mean they need to stop wearing face coverings. And those who are being vaccinated need to continue wearing face coverings. That needs to be the point raised and addressed and enforced, because what we have here is, without vaccinations, there's been a strong force against wearing face coverings, and now we're moving into the chapter of vaccinations, and there's going to be more difficulty in getting people to comply. And that's all I have to say, and I wish you all the best and Happy New Year.
Thank you, Mr. Haberman. We have time for one additional individual if they'd like to participate. And while we're waiting to see if there's anyone, Dr. Johnston put in the chat to share that there's a link on the DHSS website where individuals can provide feedback on the vaccine allocation for the state. It's through the State Department of Health, our Department of Health and Social Services, the Department of Public Health, and if you also Google it, it'll pop up. Yes, do we have someone who'd like to testify?
Hi, can you hear me?
Yes, please go ahead.
Thank you. My name is Louis Imbriani. Just hearing and looking at the dashboard for the city of Anchorage and looking at it comparatively to the Mat-Su borough, I'm looking at the adult ICU bed capacity for both, and I'm seeing that seems to be the topic that we're stressed on, is the ICU bed capacity, not only the capacity, but also the ability to staff those beds. I don't see any differentiation or any type of layout that shows the difference between the hospitals. If we're in that like red capacity as it's showing on the dashboard, why aren't patients going to these Mat-Su hospitals? If Anchorage is in a state of emergency, why aren't we sending them to like Mat-Su Regional or to another facility that's showing that they have the capacity, that they have the ability, especially for those people who are coming in on life flight, helicopter, or being flown in? Mat-Su has the ability to land the helicopter at Mat-Su Regional. I just don't know why we seem to be accepting or being the automatic hub when Mat-Su seems to be a little bit farther away. It seems like they have it. I'm not an expert on that if they have all of the capacity, but based on the website, based on what is being shown, it seems like they do. And if Anchorage is in a state of emergency, shouldn't we spread it around to another hospital that can accommodate that? It's just a question that I had, that I saw, that I can't seem to really find an answer to. That's all that I have. Thank you.
Thank you. All right, that runs us to the end of our time today. I want to thank everyone, our presenters, the health department for its great information, Mr. Carter, and everyone for attending and joining us today for what was a packed agenda. With that, I would entertain a motion to adjourn.
So moved.
All right, thanks everyone, and we'll talk to you again next month. Thanks.